Welcome to this explainer. Today, we're diving into something absolutely fascinating but incredibly high stakes. We're talking about a medical condition that acts like a slow-motion mechanical problem right up until the exact moment it turns into a sudden, deadly emergency. We're going to break down aortic stenosis, right from first principles.
Now, here's a statistic that should genuinely unsettle you. Once a patient with severe aortic stenosis develops overt heart failure, their average survival without a valve replacement isn't measured in decades. It's not even measured in years. We're literally talking about a small number of months. It's that fast.
Okay, let's dive into this paradox. Because what makes this disease so terrifying is that the very same patient can walk around for years beforehand feeling completely fine. I mean, perfectly normal. All the while, there's this fixed, unforgiving obstruction sitting right at the exit of their left ventricle, getting tighter and tighter, literally one microscopic calcium deposit at a time. The body is just brilliant at hiding this progression until suddenly it isn't.
Section 1. Anatomy of pressure overload. So, to really understand why this happens, we've got to build the mechanics of this disease from the ground up. At its core, aortic stenosis is a fixed obstruction to the left ventricular outflow. Think about it. If you want to push the exact same volume of blood through a progressively narrower door in the same amount of time, well, you need a rising pressure gradient, right? In this case, the chamber doing all that extra heavy lifting is the left ventricle. It has to generate dangerously high systolic pressures just to eject blood across that narrowed valve. And that is the absolute first principle here. The left ventricle becomes a pressure-overloaded pump, chronically working against a fixed, constantly worsening resistance.
Now, what's really interesting about this is that there are two totally different roads leading to this exact same mechanical obstruction. First, you've got calcific degenerative aortic stenosis. This is the big one for older adults. And hey, it's not just passive wear and tear. It's actually an active biological process that looks a whole lot like atherosclerosis. It shares all the same risk factors, hypertension, smoking, diabetes. Then, on the flip side, you have the bicuspid aortic valve, which is the leading cause in younger patients. This is a congenital two-leaflet valve that takes an abnormal amount of mechanical stress with every single heartbeat, and that accelerates calcification by literally decades. Plus, and this is absolutely crucial, it carries a strong risk of ascending aortic dilation, so we always have to keep a close eye out for associated aortopathy alongside the valve issue.
Section 2. The hypertrophy compensation trap.
This brings us to a major narrative pivot. It's about the body's brilliantly engineered temporary solution that ultimately becomes the very thing that kills it. So how does the heart actually respond to this crazy pressure overload? Well, it adapts by adding sarcomeres in parallel. Basically, it thickens the ventricular wall in a process known as concentric hypertrophy. This beefs up the heart so it can generate those higher pressures needed to push blood across the narrowed valve, all while keeping the chamber volume relatively preserved. And you know what? For a long time, this works incredibly well. The ejection fraction stays normal, cardiac output is totally maintained, and the patient feels absolutely fine. But this structural change is actually setting a deadly trap.
Because that thickened, concentrically hypertrophied wall, it comes at a massive cost. It gets super stiff and non-compliant, meaning it just fills poorly. This immediately causes diastolic dysfunction, driving up left atrial and pulmonary pressures, even when the heart's pumping function looks totally fine on a basic ultrasound. And it gets worse. This massive chunk of muscle now has a huge oxygen demand, but the hypertrophied wall actually compresses its own microvasculature. Plus, the elevated pressures inside the ventricle physically shorten the window during which coronary blood flow can even happen. The wall literally outgrows its own blood supply. This is exactly why these patients can experience severe angina even when their coronary arteries are completely 100% normal.
Section 3. Demystifying the symptom triad.
And this brilliantly illustrates how the classic triad of symptoms makes complete logical sense, rather than just being some random list of things you have to memorize. They are the mathematical result of the compensation trap we just built. Angina? Well, that's the supply-demand mismatch in the hypertrophied wall we just talked about. Exertional syncope, fainting during exercise? Think about it. When you exercise, your blood vessels dilate. Normally, your heart pumps way more blood to compensate for that, but with a fixed valve obstruction, the cardiac output simply cannot rise. Blood pressure plummets, cerebral perfusion drops, and the patient faints. And exertional dyspnea, or shortness of breath? That is the direct consequence of the diastolic dysfunction and those elevated filling pressures backing up right into the lungs.
Now, these physiological mechanics directly mirror what you hear and feel on a physical exam. The intense struggle to push blood through that tiny little opening creates a really harsh, crescendo-decrescendo systolic ejection murmur. It's so loud, it actually radiates right up into the carotid arteries in the neck. And if you check the patient's pulse, you're going to find it slow rising in low volume, what we call pulsus parvus et tardus. That fixed obstruction literally prevents a strong, rapid volume of flow from ever reaching the periphery.
But listen, there is a massive diagnostic pitfall you absolutely have to watch out for. Normally, we diagnose the severity of this disease by measuring how fast blood moves and checking the pressure gradient across the valve. But what happens if the ventricle is failing so badly it actually can't push hard enough to create a high gradient? This is known as low-flow, low-gradient aortic stenosis. The valve is severely narrowed, but the numbers trick you into thinking it's mild because the flow is just so weak. To properly diagnose this and avoid accidentally denying a patient a life-saving intervention, you have to use butyramine stress echocardiography to stimulate the heart or get a CT calcium scan to directly measure the anatomical calcification.
Let's move to Section 4 and see how this builds into the 2025 guideline shift.
All of these mechanics we've been talking about, they build into a massive paradigm shift in the new 2025 ESC and EACTS guidelines. The management of this disease just leaped forward faster than it has in years. First up, the age threshold for choosing a minimally invasive TAVI procedure, that's transcatheter aortic valve implantation, over an open surgical replacement has officially dropped. For anatomically suitable patients with a tricuspid valve, that threshold has moved from 75 down to 70. This directly reflects the mounting data we have on the safety and durability of TAVI in progressively younger, lower-risk patients.
But the most philosophically significant change here is how we treat patients who actually feel fine. For decades, the old paradigm was watchful waiting. You just sit tight and intervene only when symptoms finally appear. Well, the 2025 paradigm is a massive departure from that. It strongly advocates for proactive, early intervention, even in completely asymptomatic patients. Trial evidence now clearly shows a real prognostic benefit for intervening earlier in appropriately selected patients, rather than just waiting around for the body's compensations to totally run out.
So who actually gets this early intervention? The guidelines tell us to intervene if there's evidence of rapid disease progression, myocardial fibrosis on imaging, or elevated cardiac biomarkers like NT-proBNP or troponin. And crucially, if the left ventricular ejection fraction, the LVEF, drops below 55%, that is a Class 1 trigger for intervention. And I want to emphasize this. An ejection fraction drop isn't some early warning sign. Actually, scratch that. It's not a warning at all. By the time that happens, you are looking at measurable, established myocardial damage. Now, for bicuspid valves, the guidance does still lean pretty heavily toward traditional surgery, mainly because you often have to fix the aorta at the exact same time. Ultimately, this whole thing requires a dedicated heart team to plan out the lifetime management of the patient. Because think about it, a 70-year-old getting a valve today might very well need another procedure a couple of decades from now.
Which brings us to our final thought. Tracing this entirely from first principles, we see a ventricle quietly winning a fight that it absolutely cannot win forever. The very moment it exhausts its compensations, survival simply plummets. So, as we look at the newest evidence, pushing us to intervene earlier and earlier, we have to ask ourselves a really fundamental question about how we view this disease. When we practice watchful waiting in severe aortic stenosis, are we waiting for symptoms, or are we just waiting for failure? Thank you so much for joining me for this explainer. Keep questioning, keep learning, and I'll catch you next time.